And we need to repeat that the cause of compromised coronary flow is not thrombus, it is hematoma. Now we know four types of SCAD. Until soon, we knew only three. Type 1, dissection with the dissection flap present, frequency 30%. Type 2, SCAD is the most common type, frequency to 66% of cases. And type 3 is mimics of atherosclerosis, frequency 5% of case. And latest discovered is occlusion of coronary artery, and it is very difficult to different from the atherosclerosis occlusion in acute myocardial infarction. It is one of the retrospective analyses on 177 women under 15 years and younger. That women had acute myocardial infarction in 43%. And it is important to know that 9% among these 177 women were SCAD, and they didn't recognize the first time at the coronarography, only after analyze. And among these 66 women, among these 16 women, only 24% were acute myocardial infarction. And the message from this analyze is think about SCAD, because SCAD is underdiagnosed. Gold standard coronary angiography does not image arterial walls. We only image a lumen and a low index of clinical suspicion. Angiographers rely on conventional SCAD angiographics findings, multiple lumen, extraluminal contrast staining, but it's not obligatory in a SCAD patient. Not familiar with other SCAD angiographic patient, our angiographers, and very low use of IVUS or OCT. Why is SCAD important? Is SCAD important because female patients without or with a low prevalence of standard atherosclerosis risk factors are patients with a high risk for SCAD. Two hypotheses of the origin of SCAD is inside out and outside in hypothesis. Inside out, blood enter the coronary artery wall after intimal disruption, and outside in, the rupture of vasa vasorum creates intramural hematoma which compromise a true lumen. And you can see the underlying pathophysiology mechanism is hematoma, not thrombus, like in atherosclerosis, acute myocardial infarction. Those mechanisms supported in the majority of SCAD, communication between the false and true lumen is not visible in angiography. Angiograms performed in the early stage of SCAD first detected intramural hematomas and then intimal dissection. And it's very important to know that the OCT studies indicates an increased pressure in the false lumen, and fenestrates occur as a result of the rupture of the false lumen into the real one. Why is it important? When we diagnose a SCAD, anticoagulation therapy must be stopped, must be discontinued, because we have a hematoma as underlying pathophysiology mechanism. It's interesting that we started with antiplatelet therapy. With the dual antiplatelet therapy, maybe only 7 days, and after that, one antiplatelet medicament if were not in stent implanted. Why? Because we believe that in underlying of the pathophysiology of SCAD is weakness of endothelium. And the precipitation stressors are precipitation stressors of endothelium, like physical stress, emotional stress, valsalva maneuver, sympathicomimetic drugs, intensive hormonal therapy on some condition in pregnancy and postpartum. And it is a reason why we start with antiplatelet therapy. Antiplatelet therapy because we talk about hematoma, not about atherothrombosis. Precipitation factors are intensive exercise, sex hormones, valsalva training, medication, drugs, emotional stress, in one of our paper from our SCAD groups from Serbia. Prevalence of SCAD. In some randomized, some registers, we saw that the SCAD is underdiagnosed, and we think that 1/3 of patients with myocardial infarction in women under 50 years had a SCAD. But in a pregnant myocardial infarction, 43% were patients with the SCAD. First reported SCAD is in 1931, remains under diagnosis, and after 40 years, we have a bigger or a rise interesting in a SCAD. Diagnosis of a SCAD is very important to fool with the intravascular imaging. OCT, it's better, or in virus is if it is a left main SCAD, because we have a clearly delineation, true or false lumen, and better penetration with the IVUS, we can visualize full vessel extent of hematoma. Who gets a SCAD? We think that that are the woman, young woman, but you can see that there are a woman age range from 24 to 89 years, and 9.2% older than 65 had a woman in a 7 big register of SCAD. One of the biggest registries is Canadian registry, and you can see that the half of patients with SCAD are postmenopausal women. And think about SCAD and in the older woman, not only under 50 years. It's interesting that hypertension is the most frequent risk factor, and very important is the history of migraines, history of depression, and medication of depression use, and history anxiety are the most frequent precipitating or underlying disease in patients with SCAD. How can we manage the SCAD? Acute in hospital manage, long-term medical treatment, rehabilitation and exercise post-SCAD is very important, and screening for predisposing disease of SCAD. Management of SCAD studies show that it's very important the type of SCAD according to the clinical stability. Clinical stable patient with no high risk anatomy. It's a patient with a conservative therapy, 5 to 5 days stay in longer stay in a coronary care unit, but the conservative therapy, medicated therapy. But in patient with the left main but clinically stable left main, or multivessel disease but clinically stable, thinking about conservative therapy. Only patient with ongoing ischemia or an instability pressure on the stability in blood pressure, hemodynamic instability, they are patients with indication for PCI. You can see that natural history for the coronary artery dissection with the spontaneous angiographic healing without PCI, only with medication, Overall, 86% healing until to 30 days in the first month. After 30 days, 95% healed spontaneously without any PCI procedure. It is one of the proof that we can think slowly in a cath lab and to decide or are our patient for PCI or not. You can see that from Canadian SCAD registry, from the biggest registry in the world, PCI outcomes can be successful when we achieve the TIMI-3 flow and no residual dissection, partially successful residual dissection or stenosis lower than 50%, and final TIMI-3 on improved flow, and unsuccessful residual dissection or stenosis more than 50%, or worsen TIMI or extension of dissection requiring bell out. You can see that the PCI in this registry for the SCAD patient were successful in 1/3 of patient, but unsuccessful in 1/3 patient too, and partially successful in a 40%. It is a reason why we can start on why the approach to the PCI management default. No, think about medical and conservative therapy only in unstable patient. Ongoing ischemia and hemodynamical unstable patient go to the PCI. What about medication? One of the antiplatelet therapy, aspirin or clopidogrel. If we put the stent we have to start the 2 antithrombotic therapy, antiplatelet therapy until to 12 or 6 months. Beta blocker, okay, to stop or to stop heart rate, to stop the injuries from the heart rate or hypertension management on the endothelium. Strategy to prevent recurrent SCAD: beta blocker to reduce arterial shear stress, optimal management of hypertension, reduce potential precipitation triggers, emotional stress, physical stress, and avoid a hormonal therapy. What were predictor of MACE at 3 years in a Canadian SCAD registry? Genetic disorders, pericardial, and fibromuscular dysplasia. I wowould like to present our patient from our cath lab in Serbia, in Niš. It were a female, 46-year-old, chest pain. Symptoms started 2 days ago, active smoker, and lower blood pressure at admission in cath lab. You can see on the ECG that is elevation in leads 1, 2, I believe, AVL, and anterior leads. You can see this ejection fraction were 40% and akinesis of all apical segments, apical wall thickness preserved. Sudden loss of lumen on the coronarography after first septal branch, and subocclusion with indication of a little bit of flow distally. Patient is female. Right coronary artery and L6 are normal without stenosis. Side branches are preserved. Inexperienced on-call interventional cardiologists performed primo implantation DAS in the culprit lesion, but you can see that this stent were shorter, and we can see the progress of hematoma proximally. Loss of flow distally after stent placement, preserved side branch flow, and on-call doctor ends the procedure. He had no idea what to do next. Next year, you can see intimal flap at the distal edge of the stent, proximal propagation of the hematoma, distal occlusion, and angio finding suggested of SCAD. Next morning, after consilium examination, some experienced investigator, angiographers, put the workhorse wire carefully in an LAD, predilatate with a small balloon at 4 atmosphere. After predilatation, the flow a little bit improved. After placing 2 additional stents, IVUS was performed, and after that, we find that the stent were a good position, and we find hematoma, and proved that that was SCAD as a reason from acute myocardial infarction. Hematry flow, residual intimal flap present in the distal segment, and patient without new symptom. The most important thing is that the necessary to put a longer stent across to the proximal and distal ages in the patients with SCAD, if we need, that is important to place a stent. Consider that the SCAD is a reason for the acute myocardial infarction in a female, younger or middle-aged woman, tortuous coronary arteries, lesion present only one artery, usually the LAD, sudden loss of smooth lumen, preserved side branches in that culprit lesion. And what can we do? Preferred sandwich technique of implanting stents, first in a proximal segment, second in a distal segment, and the stent in the middle. Stents must be long over the ages of dissection. Positioning of stents to intravascular imaging. If Dimitri flow exists, consider conservative treatment of SCAD. First publication about SCAD autopsy findings were in 1931. It should have been here 40 years for another publication, and you can see that after 2011, interest in SCAD is growing rapidly. And one of the head of the European angiographers and the man for the SCAD registry is Professor David Adlam, our guest in our Serbian conference, and we are together work to elucidate the SCAD pathophysiology and how we can treat it. Thank you very much.
To the comprehensive investigation and function anatomy of the pericardial ligaments. Despite the scientific and technical capabilities of the modern medicine, the ligamentous apparatus of the pericardium remains poorly studied. Its function features are still unexplored. The influence of pericardial ligaments and its function under normal conditions and in the pathology are not clear. The consequences of damage of the pericardium and the pericardial ligaments during mediastinal require further research. Our aim is a comprehensive study of the morphofunctional characteristics of the pericardial ligaments, the possibility of their in vivo visualization, and the clinical consequences arising from the damage. This opens a new approach to the physiology and surgery anatomy of the heart. This slide presents Dr. Paletti drawing the ligamentous apparatus of the pericardium. We can see the arrangement of the pericardial ligaments, and they connect to key mediastinal structures. As part of pilot study, we used autopsy material with an intact ligaments complex. We conduct histological examination with various staging methods, morphometric characterization, mathematical and simulation modeling to assess traction vectors and consequences of intraoperative ligaments damage. This diagram shows the traction vectors of pericardial sac under normal conditions. Each ligament group creates a specific force direction, which is important for understanding the physiological and consequences of the damage. Pathological traction vectors. The sternotomy, a pathological traction vector, areas which can lead to function impairments. This confirms the role of the ligaments as structure and function component of the mediastinum. Result of the pilot study. We conclude the pericardial ligaments play a key role in maintaining normal heart topography and function. The damage leads to disturbance in hemodynamic and electrical stability. A detailed description of the study of the conclusion are present in previously published article. Comprehensive study. The design of the comprehensive study of pericardial ligaments include three stages: morphological, visualization, clinical. Design of stage 1, morphology. During the first stage, we perform anatomical dissection of 13 complexes of unaltered pericardial ligaments, study the physical, mechanical, using a tensile tension machine, and ultrastructural characteristics. And based on the obtained data, we create physical model of traction vectors. Visualization, stage 2. The second stage is detected to development method for in vivo visualization of pericardial ligaments, describing anatomical landmarkers, and create software for personalized modeling of traction vectors. Stage 3. Clinical trials. In the third stage, we conduct clinical trial of a new surgery technique for restoring ligaments function. We compare a group using the new technique with a control group receiving standing osteosynthesis. Our working hypotheses include the structure of pericardial ligaments ensures their function of mechanically stabilizing the pericardial sick space, while the tension force for the pericardial ligaments is physically measurable quantity. The structure of pericardial ligaments makes it possible to interval visualization in real time. Intraoperative damage to the pericardial ligaments leads to functional impairment, a result of sequentially chain of pathophysiological events, in particular to an increase in ectopia activity in the air of the pulmonary and vena cava orifices. Restore normal function of the pericardial ligaments complex will prevent the development of post-operative atrial fibrillation in cardiac surgery patients. The practical significance of the research lies in reducing postoperative recovery time, improving the quality of medical care, and reducing the economist costs of treating cardiosurgery patients. Include development of the specialized software, patent registration, and commercialization of the methodology. Understanding the structure and functional features of the pericardial ligamentous apparatus will facilitate the development of the new surgery technique to minimize the consequences of intraoperative damage to the pericardial ligaments during cardiosurgery. Prevention of the development of the pathophysiological process associated with the damage to the pericardial ligaments complex will lead to a reduction of postoperative recovery time and an improvement the quality of medical care in cardiosurgery patient. If you have any
with our result for the Serbian SCAD register. Previous presentations, we finished with this slide that only after 2011, interest and publication of SCAD is growing rapidly, you can see. But the most important position papers were from Professor David Adlan in Europe and from Canadian SCAD group from in circulation, but there are position papers only from data, registered data. We don't have until now randomized studies with SCAD. Available evidence of SCAD from the non-Western country is limited, and a knowledge gap is identifying about the global burden of SCAD in non-Western country. And recently, we had opportunity to saw that some data from the regions of non-Western population, but so far of European Western population. It is from Australia, New Zealand, Cambodia, Chile, Japan, Korea. And the first non-Western European country register is from Serbia with 14 cath lab centers. We start in November 2021, and the first result analyzed at November 2024. Spontaneous tearing of coronary artery wall resulting in formation of hematoma in wall, and I would like to remind you that the SCAD is not iatrogenic dissection, that SCAD is not atherosclerotic coronary disease, that SCAD is hematoma with outside or outside position. Okay, our SCAD group published one of the paper, Pathophysiology of Spontaneous Coronary Artery Dissection, Hematoma Not Thrombus, in Frontiers. It is important because when you made the diagnosis of SCAD in a cath lab, anticoagulation therapy must be stopped. Who gets a SCAD? A meta-analysis of 8 SCAD registries showed that the most common age of SCAD were from young to middle-aged patients. The most common risk factors were hypertension. As many as 9.2% were older than 65, and dominating number of women is in menopause. We saw that, and in the biggest register of SCAD is Canadian registry. It's interesting. I told in the previous presentation that migraines, depression, and anxiety were the most common precipitating factor for the SCAD. What we saw in our registry, we had 123 patients from Serbia. Of course, a female patient dominated. And we have a prospective patient 96, but retrospective 27. And we think that all registrars was drawing attention to the SCAD from the other entity. And it is very important that register performed. In the Canadian SCAD registry, we saw that emotional stress and isometric unusual intensive physical stress were the most important prediction factor for the SCAD. In our registry in Serbia, we saw that the stress as a precipitating factor as mental stress in 40% of patients, physical stress in 10% of patients. Our patients were in obese group because body mass index more than 26. A number of previous pregnancies was 262, and the number of live births is 196. Most women, 81%, were multiparous, but 66 failed pregnancy. It was very, very important for the further investigator. Of course, the most common risk factors were hypertension, dyslipidemia, smoking the 50%, and very interesting, we thought that hematoma is underlying pathophysiology mechanism, not atherosclerosis, but familial history of myocardial infarction was in 80% as characteristic of our patient. SCAD is underdiagnosed, we know now, because gold standard coronary angiography does not image structure of arterial walls, and we think that the most of angiographers and doctors not familiar with the other SCAD angiography patterns. But it is a reason why it is very important to diagnose and prove the SCAD with intravascular imaging. We can see that in a Canadian SCAD register, OCT or IVUS confirmed the SCAD in 7.6%, but in Serbia, it is in 26% of patients. It were necessary because we didn't know is it SCAD certainly. Okay, in a Canadian register, it's interesting. The non-STEMI is in 70% of patients as a presentation of SCAD, but in a Serbian registry, STEMI is in 70%. Why is it? Because we don't suspect that non-STEMI is that SCAD is in an underlying in non-STEMI, and it is one of the signs that we worry much more about it in the future. What can we find in a core laboratory? We find that LAD, left anterior descending artery, is the most common culprit lesion, and in Canadian registry too, in half of patients, and in Serbian registry it is in 70 patients. LAD is a common artery with SCAD. The length of lesion is too much. You can see that more than 35 millimeters. Management of outcomes of spontaneous coronary artery dissection in one of the Serbian study group is that conservative treatment should be absolutely preferred in the patient of SCAD, as PCI revascularization is linked to higher prevalence of periprocedural complication. What we found in coronary angiography on core laboratory type of SCAD is type 1 is in 14%, but type 2, as in another registry, is the most common in 44%. Okay, location of the SCAD in the vessel in the proximal or in the middle. It's the most interesting that the most common is in the distal, and it is very important for the prognosis of patient. Type of therapy in 60% we cure SCAD with medicaments, but it's important that more than 35% of a patient underwent of PCI. It's not good. We know about that. In Canadian register SCAD, the most common type of SCAD is type 2, as in our register. Okay, complication. You can see the recurrent myocardial infarction is the most common complication, and we know that that complication is a consequence of too much primary PCI in our group. Multivariant logistic regression model for in-hospital major adverse cardiac events, cardiac intervention because SCAD, and or one very interesting and something what we can't explain is statins therapy before the admission, and of course STEMI, well, with the worst prognosis according to the non-STEMI. Univariant logistic regression analyzed for hospital death show that the bad prognosis were at patient with low molecular heparin implementation and with the POBA before the PC treatment. Number of SCAD artery is one of the most important predictor for the hospital death for the patient with SCAD. Multivariant logistic regression model for hospital death, where I repeat POBA, number of SCAD arteries, and heparin therapy. Of course, a regression model for MACE after 30 days, depression, implantation of stent, and think about it. I told about it that the natural history of spontaneous coronary artery dissection, spontaneous angiographic healing in this retrospective analysis were well good, but in our analysis we performed coronarography in mid-time 38 days, and the findings after recoronarography was that full resolution of SCAD in 62% of patients, and the SCAD in progression in 2.7%, in other artery 2.7%, and it is one of the proof that the conservative therapy is better than PCI. Several common genetic risk lots for SCAD are shared with coronary artery disease, but have a directionally opposite effect and a different genetic contribution of established cardiovascular factor. These findings implicate arterial integrity related to extracellular matrix biology, vascular tone, and tissue coagulation in the pathophysiology of SCAD. It is important that this Mendelian randomization association between main cardiovascular risk factors SCAD and coronary and atherosclerotic coronary artery disease, that HDL cholesterol, it is important that's the same as the risk factor, but the LDL is different as the risk factor. It's very, very interesting. What do we know so far about SCAD? Thinking about SCAD in cath lab, performing intravascular imaging more often for diagnosis of SCAD. When SCAD is suspected, the absence of calcium on MCT is highly probability for SCAD. Don't expect only young and pregnant women with acute coronary syndrome with SCAD. Immediately after established diagnosis of SCAD, turn off the heparin, TIMI 2 to 3 flow, acute coronary syndrome, and SCAD do not touch. What do we don't know so far about SCAD? It is necessary to create a risk score and risk prediction of SCAD, to conduct more register for Eastern transitional country, and genetic testing SCAD patient is necessary. Beta blockers to reduce arterial shear stress, optimal management of hypertension, reduce potential precipitation triggers, emotional stress and physical stress, avoid hormonal therapy in symptomatic substance. And thank you very much for your attention.
Thank you, Doctor, for your excellent presentation.
So today we're presenting a case report on a challenging case of infective endocarditis. So some clinical background is a male in his 60s with multiple comorbidities. He has COPD, ischemic heart disease, previous ST elevation MI, with subsequent heart failure with reduced ejection fraction. He also had a ICD inserted for prevention of ventricular tachycardia, and he had a background of duodenal stricture and alcohol dependency. So initially, this patient presented with a 1-month history of weight loss, poor appetite, and malaise. He was assessed in gastroenterology clinic and admitted for further investigation. He developed a fever overnight on the ward, and a septic screen, including blood cultures, was performed. Empirical IV antibiotics included coamoxiclav, gentamicin, and metronidazole. And due to his poor nutrition, he was assessed by the dietitians who started total parenteral nutrition. So, due to his symptoms, a CT thorax, abdomen, pelvis was requested to investigate for malignancy. This actually showed suspicion of discitis at the L3, L4 intervertebral disc, and there was no evidence of malignancy. So, to confirm the CT suspicion, an MRI was requested, which confirmed acute spondylodiscitis at L3 and L4. Repeat blood cultures were taken, which showed a positive Candida infection in the bloodstream. So the initial source of this Candida bloodstream infection was the gastrointestinal tract, and he was started on intravenous andilofungin. So this is the MRI image, which shows subtle increases at the L3, L4 end plates with some L4 fragmentation. So he went on to have a OGD, which was performed to evaluate possible source of Candida infection, the findings of which showed a smooth, benign, short stricture at the D1, D2 junction with fibrotic appearance. And histology from the biopsies taken showed duodenitis. So these findings do suggest possible translocation of Candida from the GI tract. So during the admission, he developed sudden hypertension and new oxygen requirement. He had a 4-day history of loose stools, although the stool cultures were negative. He had received one ICD device shock, and that was interrogated and confirmed ventricular tachycardia, which he had a past medical history of. After discussion with microbiology, he was switched from coamoxiclav and gentamicin to ceftriaxone alongside the metronidazole and andilofungin. So his case was discussed at the gastroenterology MDT, where they determined that there was evidence of gastric outlet obstruction as a cause of his weight loss, poor appetite, and malaise. And they thought that the gastric outlet obstruction was related to duodenal stricture, and that contributed to his prolonged poor nutritional status. So further along in the admission, he had a troponin rise alongside these ICD firings. Cardiology reviewed the patient, and they thought that the troponin had risen due to the episodes of ventricular tachycardia, so rate-related rise. And the initial transthoracic echocardiogram was reported as no change in his heart function from the previous echocardiogram, and no evidence of endocarditis. Ophthalmology also did not find any evidence of endophthalmitis. So he continued to have temperature spikes during the admission. Microbiology was contacted again, and they advised to stop the andilafungin and metronidazole. He was started on IV fluconazole, ertapenem, and vancomycin. He also had some intermittent delirium, and a CT had found a non-specific CSF density cyst, which was managed conservatively. So he had continued ICD shocks with episodes of ventricular tachycardia. ECG showed some subtle ST elevation with T-wave inversion in the inferior leads. His troponin rose to 222, and the primary PCI pathway was activated. However, after the cardiologist had reviewed the patient, they advised that to replace the magnesium and focus on electrolyte imbalances as possible cause for VT episodes, and did not take him for a procedure. So after rediscussion in microbiology, we sent off more cultures. We tested for HIV, brucella, serology, and TB spot test. Antibiotics were modified to fluconazole, andilafungin, and teicoplanin. Repeat CT tap showed upper lobe atelectasis and pleural effusions. There was apical chronic myocardial infarction, which we already knew about, and no pericardial effusion. And he also had a small segmental PE confirmed on CTPA. So due to his clinical picture and symptoms, and also because he had an ICD in situ, he was deemed still high risk for endocarditis. So they went on to have a repeat echocardiogram around 7 days after this, which showed a vegetation on the tricuspid valve. His case was discussed urgently at the endocarditis MDT, and microbiology changed his antifungal to added in liposomal amphotericin B to fluconazole, andilafungin, and teicoplanin. As per the ESC guidelines, the ICD is extracted to remove potentially infected hardware. Cardiothoracic input was considered, but patient was deemed too high risk for surgical excision of the tissue, and therefore he was managed conservatively with a prolonged course of antifungal treatment. So this is an image of the echo. You can see the lead here and the tricuspid leaflet vegetation. So we sought for mycology subspecialty expert advice regarding what regimen of antifungal treatment he should be on. He had an NJ tube inserted by gastroenterology for his stricture. He was weaned from TPN onto NJ feeding. Cardiology screened him for possible subcutaneous ICD reimplantation and thought to see him as an outpatient to discuss further. And the repeat echocardiogram showed interval improvement in vegetation with mild tricuspid regurg. So the final outcome in his discharge, the patient was sent home on NJ feeding regime. He went sent home on oral voriconazole and oral posaconazole for 6 weeks. As an outpatient, he had a follow-up echocardiogram approximately 6 weeks later, which showed no obvious remnants of endocarditis, and he completed the antifungal regimen. His ICD was reimplanted in a different site as an outpatient. So I'll hand over to my colleague, Dr. Mustafa, who will talk through the rest.
Thank you, Zia. So a quick look about the epidemiology and risk factors of this case. Bloodstream infections are a leading cause of hospital admission and in-hospital mortality. It can cause to sepsis in patients. There is an increasing number reports of bloodstream infections due to fungal infections and yeasts, including Candida. There was a previous research that showed Candida species account for about 5 to 10% of bloodstream infections. The risk factors usually include diabetes, increasing age and frailty, immune-suppressed patients, and having indwelling devices, such as in our case, the ICD. In this case, the patient had few risk factors, including the age, frailty, the presence of ICD as well. Next, please. So there was some diagnostic challenges in this case. The blood cultures for Candida usually have poor sensitivity and prolonged turnaround times. The symptoms related to the fungal infected endocarditis are not as severe as the bacterial infections, and it's usually more of chronic debilitating symptoms as of weight loss, malaise, lethargy, and diaphoresis. And also TTE and TOE, focusing on fungal endocarditis, report sensitivity of around only 77%. So regarding the management and guidelines in this case, there was a research reporting 19% increase in 1-year survival when surgery and antifungal treatment were used together for fungal endocarditis. For native valve endocarditis, Candida endocarditis, the recommended treatment was to combine surgical treatment within 1 week with antifungal treatment for 6 to 8 weeks. Surgery where vegetations more than or equal to 20 millimeters for right-sided infected endocarditis or persistent tricuspid vegetations after completing the treatment. Again, in our patient, there was multiple challenges here, including the comorbidities and the significant frailty. And all of this has led to the decision that he's not suitable for surgical intervention. According to the guidelines, when there is a cardiac implanted device endocarditis, complete system extraction is advised in these patients. Back to the fungal endocarditis is more frequent in patients who are immunocompromised or who have prosthetic valves, and also in patients with implanted cardiac devices. Most commonly, it would be Candida or Aspergillus. Patients having cardiac implanted devices related right side infected endocarditis have a worse prognosis compared to those without a cardiac implanted device. Right-sided fungal infected endocarditis in immunocompromised patients carries a very poor prognosis. The Candida discitis in our patient here, the MRI showed partial disc and end plate involvement with focal soft tissue abnormality. In a prior research, it was found that partial disc end plate involvement to be significantly associated with Candida discitis. Luckily, in this patient, the discitis did not progress to severe erosion, allowing for conservative management without the need for spinal surgery. So, in conclusion, this case here highlights the challenges of managing a patient with multiple comorbidities and invasive Candida infection. The symptoms that he presented with led to diagnostic process that revealed later that he has a Candida bloodstream infection, spondylodiscitis, and fungal infected endocarditis. Risk factors in this case was duodenal stricture, duodenitis, cardiac implanted device, and frailty. The frailty and unsuitability for surgical intervention for fungal endocarditis limited the options of management and contributed to a more comprehensive conservative management. The key learning points from this case is that invasive Candida infection should be considered in older and frail patients with indwelling devices, weight loss, and unexplained sepsis. Fungal endocarditis often presents with non-specific symptoms rather than the classic bacterial infected endocarditis features. Yearly repeated imaging and appropriately timed blood cultures are essential in the clinical picture as the clinical picture evolves. In the ESC guidelines, it suggests repeating the imaging in 7 days. In patients who are not surgical candidates, conservative management relies on prolonged antifungal treatment device extraction if the patient has any, and robust nutritional and supportive care. Of course, all of this wouldn't have been pulled together if it's not for the multidisciplinary approach that was carried out with this patient. But even with this, conservative management of fungal endocarditis carries a significant mortality risk. These are the references, and thank you. If there's any questions.
Thank you for your wonderful presentation. Any questions from the audience?
On the diagnosis and treatment of arterial hypertension. My name is Pascual Valdez. I am an internist and an intensivist from the Republic of Argentina. I belong to the Argentine Society of Medicine, and I am the president of the International Forum of Internal Medicine. And we are going to present this work, which was recently published in the journal Clínica Española. It refers to the updated diagnosis and treatment of arterial hypertension, the 2025 guidelines, in which 6 authors, 54 co-authors, and 23 internal medicine societies from 21 countries participated. This is the citation and its location in PubMed for this publication. And here we are going to mention, as some background from our working group, a publication on the Latin American recommendations for the management of arterial hypertension. This was a 2019 publication in a journal called Acta Médica Colombiana and in the Journal of the Paraguayan Society of Internal Medicine. They are also from our working group. And in 2023, we issued a position statement from the International Forum of Internal Medicine on habits, lifestyles, and a healthy environment in the prevention of cardiovascular diseases. The topics we are going to cover in this session are initial diagnosis and classification, cardiovascular risk assessment, routine tests and additional studies, treatment, resistant hypertension, and special situations. Regarding the initial diagnosis and classification, what we propose is that to diagnose hypertension, we require 2 to 3 visits with an interval of 1 to 4 weeks, using the average of the last 2 out of every 3 blood pressure measurements. Per visit, using an appropriate measurement technique. And as much as possible, we need to confirm this diagnosis with measurements taken outside the office to avoid the white coat phenomenon and masked hypertension. And the classification is based on categories ranging from optimal to grade 3. And this is in accordance with the European guidelines. So we have a classification of optimal blood pressure, which is below 120 and 80 millimeters of mercury. Then there is normal, which is between 120 and 129 and 80 to 84. High normal is 130 to 139 and 85 to 89. And so we go up, considering grade 1 hypertension starting at 140/90. Then there are concepts of grade 2 and grade 3 hypertension, as well as isolated systolic and isolated diastolic hypertension. But our key point is 140/90. Now, depending on the type of blood pressure measurement, we have different cutoff points. The one we've mentioned, 140/90, is the measurement taken in the office. But then we have the ambulatory monitoring method with devices, which can be daytime or over 24 hours. So the cutoff points for daytime are 135/85. For nighttime, 120/70. And for the 24-hour average, it's 130/80. And then we have self-measurements, which are 135/85. We must rule out orthostatic hypotension, especially in patients who have symptoms suggestive of it, in older adults, in diabetics, or in patients with neurodegenerative diseases. Blood pressure should be measured after 1 minute of standing and then repeated after 3 minutes. A drop of 20 millimeters of mercury or more in systolic blood pressure compared to when the patient is seated establishes the diagnosis of orthostatic hypotension. And we also have to keep in mind that there are 4 phenotypes that result from the combination of normal or elevated blood pressure. In the office, ambulatory care. So when both are high in both scenarios, it's true hypertension, and when both are normal in both scenarios, it's true normotension. Now, when we have high blood pressure in the office and normal in ambulatory care, this is called white coat hypertension. And when it's, high in ambulatory care and normal. In the office, we talk about masked hypertension. And looking at the concept of coronary prevention, we should not diagnose arterial hypertension with just a single reading, nor with devices that are not the most appropriate, nor in inappropriate clinical contexts, or in just one visit. Because these values can vary due to multiple factors related to the operator, the equipment used, or the environment, which is why a single measurement is inadequate, except if the patient has 180/110 or higher. In that case, yes, we diagnose arterial hypertension. Now, to assess cardiovascular risk, this is done in patients with hypertension or with high normal blood pressure, which can influence therapeutic management. We should use certain scores, such as, for example, the score 2 or the 10-year G-ARDS risk in patients without established cardiovascular damage and without evidence of target organ damage. Now, it should be kept in mind that risk assessment should not delay the initiation of hypertension treatment if it is indicated. There are new guidelines that are incorporating cardiovascular, renal, and metabolic risk. And at the same time, hepatologists are interested in including fatty liver as a new variable that influences risk assessment. So here we have some options. In the columns, we have the options of normal, high, hypertension, grade 1, grade 2, and grade 3. And in the rows, we have patients without cardiovascular risk factors, with 1 or 2 factors, with 3 factors, or target organ damage or kidney disease. Chronic grade 3 or diabetes without target organ damage, or with established cardiovascular disease. Kidney disease grade 4 or higher, or diabetes mellitus with target organ damage. Based on these combinations, we will have patients who are at low risk, moderately high risk, or very high risk. This is an assessment we always have to do. It's not just about the blood pressure reading. It's the presence of risk factors and/or damage. But we also have to take into account some other elements that we internists look at, which are not usually included in the vascular risk table, such as socioeconomic factors. It's well known that lower socioeconomic levels are associated with higher risk. Psychological factors such as stress, anxiety, depression, isolation, loneliness, autoimmune diseases, chronic inflammatory diseases, people living with HIV, oncological diseases, a history of hypertensive disorders during pregnancy, polycystic ovary syndrome, premature menopause, and environmental risk. So, on one hand, we have the concept of target organ damage mediated by hypertension, for example, increased arterial stiffness, the presence of atheromatous plaques, and kidney diseases. In stage 3, albuminuria, measurement of the ankle brachial index, or advanced retinopathy. But we can also talk about silent disease. Established cardiovascular or renal disease occurs when a person has had a stroke, either ischemic or hemorrhagic, a transient ischemic attack. when there is clinical evidence of coronary disease, when there is an atheromatous plaque with hemodynamically significant stenosis, when there is heart failure, peripheral vascular disease, atrial fibrillation, or kidney disease. Chronic kidney disease stages 4 and 5 or significant albuminuria. And what are the routine and additional studies? Well, first of all, having lab tests that include a lipid profile, blood glucose, renal function, thyroid hormones, and a urinalysis with the albumin to creatinine ratio. An electrocardiogram which helps us detect left ventricular hypertrophy, arrhythmias, or ischemia. An echocardiogram if available to assess cardiac function and structural damage. And other studies to consider, but these depend on the clinical suspicion for secondary hypertension or for risk stratification. So for example, if we are going to suspect secondary hypertension, here we have a first column showing the etiology, a second with the clinical suspicion, and a third one, which would be the detection methods. So if I'm thinking about renovascular disease due to atherosclerosis and fibromuscular dysplasia, we will suspect it if there is severe hypertension at onset with progressive renal failure, if there is resistant hypertension, if there is a sudden increase in blood pressure, or if there is an increase in serum creatinine. After administering angiotensin-converting enzyme inhibitors or angiotensin receptor blockers, if there is moderate to severe hypertension in a patient with renal asymmetry, if there are repeated episodes of pulmonary edema, or if there are abdominal brutes. And in this case, the methods that will be used for detection are Doppler ultrasound of the renal arteries, CT angiography, or MR angiography. Another possible etiology of kidney disease is parenchymal disease, where we find some signs such as edema, oliguria, clinical manifestations of uremia, pathological urine sediment, among others. And the detection methods are renal ultrasound, measurement of glomerular filtration rate, urinalysis, and the urinary albumin to creatinine ratio. And in this way, we can consider pheochromocytoma, paraganglioma, primary aldosteronism, Cushing's syndrome, obstructive sleep apnea syndrome, or aortic coarctation. Here in the middle column, we will see which are the elements of clinical suspicion, and on the right side, what are the methods we can use for detection. Regarding treatment, we will start pharmacological treatment in every person aged 18 or older with blood pressure, 140/90 plus lifestyle changes. In people aged 80 or older, we will individualize the initiation of treatment, taking into account their frailty and tolerance to treatment. Here, the starting point, let's elaborate a bit, will be between 140 and 140 and 150 millimeters of mercury. At the same time, we will also start it in patients with normal blood pressure. High, meaning those with 130/85 or higher, who have high risk or established damage. In these patients, we will also initiate treatment for arterial hypertension. The goal is to achieve a systolic pressure between 120 and 129, and a diastolic pressure between 70 and 79 if well tolerated, and in all cases, avoid a diastolic pressure below 70 millimeters of mercury. And in people aged 80 or older, the target will be just below 140/90. The treatment will include angiotensin-converting enzyme inhibitors, angiotensin II receptor blockers, calcium antagonists, or thiazide diuretics as first-line drugs. And we will initially prefer combination therapy in a single pill if it is available. We will avoid combining the use of angiotensin-converting enzyme inhibitors with angiotensin receptor blockers. This is a combination to avoid. We will progress to triple therapy. If there is no response after therapy with 2 medications, we will move on to 3 medications, and we will titrate every 2 weeks whenever it is possible in order to achieve the goal within 3 months. Now, although we have talked about combined dual therapy, there are some cases where we can start with monotherapy. In those cases, it would be in grade 1 hypertension, close to the lower limit, below 150/95, with low cardiovascular risk. Another case is patients with high normal blood pressure and elevated cardiovascular risk. And another case is people aged 80 or older who are frail, in whom it has been decided to start treatment. It is possible to start with a single drug. The preferred combination should include either an angiotensin-converting enzyme inhibitor or an angiotensin receptor blocker, along with a calcium channel blocker or a thiazide or a thiazide-like diuretic. As for beta blockers, they may be combined in very specific special situations. For example, if there is coronary artery disease, heart failure, or a need to control heart rate in patients with tachycardia, among other situations. Here, this diagram shows us the combination of an angiotensin-converting enzyme inhibitor or an angiotensin receptor blocker, plus a calcium channel blocker or thiazide diuretics. The targets are monitored and the dose is increased to the maximum if necessary and if tolerated. And if blood pressure is not controlled, ideally with a single pill. And if blood pressure still cannot be controlled, all 3 medications are added. Again, the targets are monitored and the dose is increased to the maximum if necessary and if well tolerated. We will also implement lifestyle modifications and promote a healthy environment. For example, restricting salt intake to less than 5 grams per day, avoiding or limiting alcohol consumption, following a healthy dietary pattern, reducing and maintaining weight, engaging in regular physical activity with 150 minutes per week of moderate intensity, avoiding a sedentary lifestyle, and quitting smoking. Getting adequate sleep in both quality and duration, 7 hours a day. Manage stress with various techniques and take precautions in the presence of high environmental pollution. Consider the possibility of white coat hypertension, which refers to high blood pressure readings in the doctor's office but normal readings outside of it. Currently, pharmacological treatment is not recommended for these patients, but it should be considered if they have a high cardiovascular risk or evidence of target organ damage. So in patients with white coat hypertension, it is recommended to implement lifestyle changes and monitor their blood pressure values periodically outside the doctor's office. We also need to look at some strategies to improve patient adherence. And adherence, there are interventions at the level of physicians, patients, therapy, and the healthcare system itself. For physicians, we should communicate using clear language, empower patients, provide positive reinforcement during treatment, and identify what the barriers are. For patients, they should monitor their blood pressure at home, use reminders, pill organizers, and involve their family. For therapy, it is essential to simplify the therapeutic regimen, aim for medications that can be taken once daily, and use single pill combinations. And for the healthcare system, implement follow-up systems, such as phone calls, telemonitoring, etc. Another thing we need to improve is clinical inertia. This is defined as a failure or delay in starting or adjusting therapy when it is indicated. And this can be due to several factors, such as insufficient medical education, brief consultations, high professional thresholds for considering blood pressure as elevated, or errors in clinical reasoning. What is the impact high prevalence of monotherapy, and inadequate control of hypertension. And it is recommended to actively recognize this, use therapeutic algorithms, and initiate early dual combination therapy. Consider the support of telemedicine in patient follow-up. We know that the context is an increase in the use of technologies. The benefit is improved adherence and self-care. And a significant reduction in blood pressure has been calculated to lower it by up to 6 millimeters of mercury. The strategies include telemonitoring, mobile applications, or data transmission. And digital integration is recommended, as well as trying to overcome traditional barriers. Next, a paragraph on resistant hypertension. It is considered resistant hypertension when therapeutic goals are not achieved with 3 drugs. However, we must always ensure that a diuretic is included, that the doses are appropriate, that the measurements are accurate, and that adherence is good. Because if all these requirements are not being met, we cannot speak of resistant hypertension. The diagnosis is confirmed with ambulatory measurements, which allows us to rule out white coat hypertension, and we must also consider evaluating for secondary hypertension. And before confirming resistant hypertension, always rule out pseudo-resistance, which refers to improper techniques, inadequate combinations, or low doses. The approach is to add a 4th drug, and that drug is spironolactone. And if it is not well tolerated, eplerenone or amiloride should be considered. In some cases where there are neurogenic components, beta blockers can be used. In certain specific patients, renal denervation may be considered. And in these complex patients, consider referring them to specialized centers. Now let's look at some special situations. For example, hospitalized patients who have hypertension, who are admitted for another reason, not a hypertensive emergency, and are found to be hypertensive. Well, consider a few things such as the proper measurement technique, the correct cuff size, validated devices, evaluating causes of transient elevation such as pain, anxiety, certain medications, whether it's the omission of the patient's usual drugs or the use of drugs that increase blood pressure like non-steroidal analgesics, corticosteroids, and withdrawal symptoms the patient may experience, hypovolemic states. These are all conditions that are often present in hospitalized patients. Hospitalization itself increases cortisol, and cortisol raises blood pressure. What should be avoided is increasing or intensifying antihypertensive treatment if the patient has no symptoms or target organ damage. And upon discharge, when the patient leaves the hospital, it is important to coordinate and reconcile their medications and to ensure continued monitoring and adjustment of antihypertensive therapy if necessary. Another topic is hypertensive emergencies, which are cases where patients have acute target organ damage. It is the presence of this organ damage that defines a hypertensive emergency, not the blood pressure value itself. An emergency is not defined by a specific value, but by the presence of target organ damage. Now, the term that is often used, which is hypertensive urgency, should be eliminated. We should no longer talk about hypertensive urgency, because these are patients who do not have acute organ damage, target organ. They may have chronic damage, but not acute damage. Therefore, if the damage is not acute, there is no need for an immediate reduction in blood pressure values. Another scenario is hypertension during pregnancy. It affects 10% of pregnant women, defined by a systolic pressure above 140 and or a diastolic pressure above 90 or more. The risk is the increase in maternal fetal morbidity and mortality with preeclampsia and cardiovascular disease. The treatment is with extended release nifedipine. With labetalol or methyldopa, ACE inhibitors or angiotensin receptor blockers are contraindicated. Lifestyle measures must be taken, and the therapeutic recommendations are to start pharmacological treatment at 140/90 or higher, with the goal of getting below 140/90. Ambulatory monitoring should be done to detect white coat hypertension or masked hypertension, and there is no evidence to support reducing values below 130/80. It can be between 120 to 129, 70 to 79, and we have no evidence for those values. Older adults. The prevalence of hypertension in this group is 70% when they are 65 years or older. Here we need to consider frailty, cognitive impairment, and orthostatic hypotension. And treatment is indicated when people have 140/90 or higher, and the goal is just below 140/90. That's for those between 65 and 80 years old. Above 80 years old, we can allow the systolic pressure to be a bit higher, between 140 and 150. And in frail patients, we can stretch it a bit further, up to 160 as a threshold to start therapy. And in no case should the pressure be below 70 millimeters of mercury. And always, as a recommendation, individualize the targets and prioritize safety. Patients who have both hypertension and diabetes, this is a common coexistence. The target is between 120 and 129 for systolic pressure and between 70 and 79 for diastolic pressure, if it is well tolerated. The treatment is with angiotensin-converting enzyme inhibitors or angiotensin receptor blockers as first-line therapy, combined with calcium antagonists or thiazide diuretics. But as an additional recommendation, we should also consider the use of SGLT2 inhibitors and GLP-1 receptor agonists due to their important cardiovascular and renal benefits. Regarding chronic kidney disease, which involves mechanisms such as sodium retention, sympathetic activation, and activation of the renin-angiotensin-aldosterone system, our therapeutic goal is to maintain levels below 130/80. The treatment is with angiotensin-converting enzyme inhibitors or angiotensin receptor blockers, always without exception, carefully avoiding dual blockade, and loop diuretics. If the glomerular filtration rate is below 30 milliliters per minute, sodium restriction and combination therapy are recommended when chronic kidney disease is advanced. Regarding chronic pain and the use of analgesics, they have a strong relationship with blood pressure because pain increases catecholamines and raises cortisol levels. The impact of analgesics is to increase blood pressure and cardiovascular risk, and in turn, they can reduce the effectiveness of antihypertensive drugs. The recommendations are to limit the use of anti-inflammatories, use the lowest effective dose, and for the shortest possible duration. And as an alternative, be sure to consider weak opioids, topical treatments, and avoid effervescent formulations that contain sodium. Well, thank you very much for your time. These are the email addresses for any questions you may have. Thank you very much.
Simón Bolívar from Barranquilla, Colombia. It's a pleasure to be here with you. Today I will present the results of my article titled Symptoms Control in Individuals with Advanced Heart Failure in Palliative Care. The purpose of this presentation is to explore how early palliative care by lead nurse can improve symptom control and quality life of people with advanced heart failure. Cardiovascular disease remains one of the leading causes of disability and death around the world. Heart failure represents the final stage of many cardiovascular conditions that begins as acute event or later evolve into chronic disease. Millions of adults in the United States live with a heart failure. The number has been growing and is projected that more than 80 million adults that will affect between the years 2012 and 2030. Globally, the prevalence of heart failure is between 1 and 2%. In my country, Colombia, is researched to 0.3%. In science also grows sharply with the age, around 2 cases per 1,000 people between 35 and 64 years old and 12 cases per 1,000 people between 60 and 5 and 94 years old. This trend showed how important is this trend of preventions, treatment, and long-term care in this pathology. Heart failure is defined as a problem in the contraction and relation of the heart muscle. This problem usually comes from a structural and muscular change in the heart. This condition produces high pressure in the lungs and the venous symptoms, and reduced volume in blood ejected by the heart, low cardiac output, and difficulties in circulation. Patients frequently experience symptoms such as shortness of breathing during the daily activities, tiredness, and fluid retentions. Diagnosis often occurs after the sudden health event or after a gradual worsening of the chronic disease. Clinical guidelines classify heart failure stage 2A to D from the ACC and the AHA based in the risk of symptom and other symptoms. Another classification considers the functional limitation in 4 levels from mild to severe to very severe. Patients in most advanced group experience shortness of breath, reduced tolerance to physical activities, and worsening symptoms even with the mild effort, and sometimes symptoms at the rest. Palliative care originally focused on controlling adverse effects of cancer treatment. Today, it includes rehabilitation and psychosocial support for people living with chronic and life-limiting disease, including cardiovascular disease. Symptoms control is central component in palliative care in a study from the symptoms, shared cases, and ways to integrate cares of coordinate model. Heart failure needs early palliative care because it's a progressive and potentially fatal disease with symptoms that continue to increase over time. Around the world, nurses are often the closest professional to patients and families. In many situations, they are only the visible health staff. Their work is based in caring, listening, education, research, management, and advocacy. For this reason, their interventions are essential for controlling symptoms in advanced heart failure. For that reason, the objective of the review was to systematize and evaluate the evidence regarding from the most effective nursing intervention in primary care for people with advanced heart failure in chronic care. I conduct a systematic review using the main scientific sources: Virtual Health Library, Science Direct, and PodPen. I use 4K term, mesh term to heart failure, palliative care, nursing, and symptoms management. I include studies that report nursing intervention from adults with advanced heart failure with the highest level and research quality. We assessed a study that published in English and Spanish between the years 2010 and 2024. To exclude articles, we first check titles, abstract, and later I removed those that did not report relevant results. I use an international recommendation for this systematic review, like PRISMA methodology, quality evaluation, like CASP, that is el Programa de Habilidades de Lectura Crítica en Español, and levels of evidence from the OSEM from the Oxford University. Also, an independent external review was used to reduce all the papers that was included. At the beginning of the search, I identified 4,257 articles. After applying the relevance criteria, 4,116 were excluded by title, followed by the elimination of 35 papers by abstract and 10 duplicate record. After that, I exclude more than 3,000 articles because they did not meet the research design criteria or because they had poor quality or presented unaccepted bias. After the rigorous process, only 50 articles were finally included in this review. All 15 articles were evaluated with standardized tools for quality assessment, and the average score was 80%. This means that the evidence that will present come from a robust, reliable, and well-conducted research. Now, can you see in the table 1, which summarize the methodological strength of the study, including this review. In total, I identified 460 reviews classified as level A, 1A, and 11 randomized clinical trial classified as level A, 1B, based on the recommendation of the Oxford Center for Evidence-Based Medicine. This classification means that evidence supports nursing intervention for palliative care symptom control is grounded in highly quality, experimental, and systematic review. Most of the randomized trials demonstrate that a low risk of bias in categories such as selection, performance, and detection. Even the study were not blind. For example, the study carried for the Braston, Rogers, and Hobbs were open label, but they were still considered low risk, which indicates that their outcomes are reliable and valid. Overall, the strength of methodology allows us to confidence that the data presents here can be support decision making a clinical practice. The slide include that Table 2 and Graph 1. Table 2 show the evaluation performed with a standard critical appraisal instrument, and the studies achieve an average score of 60%, which demonstrate the high methodological rigor. For other hands, Graph 1 illustrates that symptom burden in advanced heart failure, which is a highly consistent finding across the literature. Patients frequently report shortness of breath, fatigue, pain, swelling of legs, symptoms of depression, and anxiety, emotional distress. These symptoms are the most common reason for emergency visits, hospital readmission, and transition to higher levels of care. In addition to physical discomfort, many studies report spiritual distress, difficulties adapting to illness, challenges in coping, and strong emotional impact related to prognosis and awareness approaching to the end life. All these elements make the clinical situation complex and they strongly reinforce the importance of early palliative care strategies where nurse plays a central role in the symptoms assessment, communication, and support. The study that showed the symptoms in control in advanced heart failure needs a reliable assessment tool. Two instruments were used the most frequently. The first one was Edmond Symptoms Assessment Symptom, which measures the symptom on a scale from 0 to 10 and produce a total symptom score. The second was the Patient Health Questionnaire with 9 questions, which identify the perceived symptoms. There's instruments support clinical decision and reveal the patient experience in heavy burden in physical and emotional symptoms. The most effective nursing intervention include educational and behavioral strategies that improve self-care and reduce hospital readmission. Multidisciplinary palliative care approach produce significant improvement in quality of life. Medicine for depression show that mixed results, but still improve emotional and social well-being. Spiritual and end of life support increased comfort and inner peace. Overall, the evidence confirms that nurse-led assessment intervention are essential in managing complex symptoms in advanced heart failure. Palliative care acts a extended experience that treating physical symptoms, emotional concern, psychosocial factor, and spiritual needs. Therefore, it should be not be viewed as only as a last option at the end of life. In advanced heart failure, palliative care can relieve symptoms, support decision making, and reduce hospitalization and improve comfort in dignity. Nursing offer a unique view that consider how patients feel and how they understand their illness. This open conversation about the future health, expectation, and quality of life. The story showed that nurses with training and palliative care or cardiology provide more than effective intervention. However, training is not uniform. For this reason, we need more specialized graduate from education from nurse in heart failure and palliative care. Many finds in the file historically came from the cancer research, but now research focus exclusive on heart failure, improving benefits in symptoms relief and quality of life. This review recommends beginning palliative care early during initial symptoms, during acute episodes, and also during the advanced chronic stage. There's also a clear need for more quantitative studies and randomized trials in Latin America. Finally, in conclusion, early integration of palliative care led by nurse significantly improved symptoms and control and quality life in advanced heart failure. This is not only the clinical recommendation, and it's an urgent need because it's a transform care into human, comprehensive, and evidence-based model. Thank you to everyone for your attention.
Thank you, Doctor, for your wonderful presentation. You can share your email ID in the chat box. If anyone has any question, they will email you. Thank you.
Thank you, everyone.
I created for open chest resuscitation of the post-cardiac surgical patient. We're going to talk about the case that kind of prompted this whole simulation. I'm going to go through the simulation and the design of the mannequin, and then some of the changes that we discovered and what we made occur from the simulation. This case was a pretty basic case initially. Just some quick background of the facility I come from. We have 10 hospitals in our network. One hospital is our tertiary center that is the main center for all the cardiac and as well as other services. And they were helping to establish robust cardiovascular surgical centers in our two other outlying facilities. The one facility was trying to get their program a little more robust, and these physicians from the tertiary center were going out to train these physicians. There was a case, and I have it up here, was just a pretty 65-year-old male, had a one vessel CABG, really no problems, made it back to the CVICU, and everything was going good. Well, then all of a sudden, he started to become hypotensive despite efforts with neosynephrine or neoepinephrine infusions. He developed a fib arrest and he arrested. The resuscitation went quite a bit of confusion. The CT surgeon who did the case was actually from our tertiary center, so he was used to very well-trained staff and was used to all of his equipment and everything done his way. So there was a lot of confusion between the nursing staff, what was being used, terminology, who should be in the room, where they should stand. But ultimately, everything went well. The patient was opened. There was no blood, but they did see blood in those ventricles, and he was returned to surgery, and everything went fine, and the gentleman did fine, and he survived. Afterwards, the cardiothoracic surgeon reached out to me, and we were talking about how we could improve the education. And I said, through simulation, we could do that. And I've done simulation for the last 6 years and done a lot with what we call root cause analysis after there's an event. And we take those details, create a sim, run the simulation, and a lot of times we can find where some improvements can be made. So in beginning to figure out the simulation, I had to find a mannequin. And looking around and looking at what was already out there commercially made, there really was not a really good viable source or a viable mannequin to use for the simulation. What I could find was quite expensive. There was only a couple out on the market, and they were literally between $50,000 to $100,000 a piece. So we do have a lot of old retired mannequins, and for lack of a better word, pieces and parts in our basement from old mannequins. So I went and looked, and I used an old Resusci Annie. For those of you that remember this mannequin from back in the 90s, and figured this was a good one. I needed to find a mannequin I could open the chest on. And this simulation was really focused on process. And we wanted to make it wasn't as much having a high-tech mannequin as much as to be able to go through those steps and figure out how we can improve that whole process, which is such a high risk, low volume occurrence. So we use this mannequin. We did put all what I call fluff, put a central line in, we put a triple M in Swan, made it look like they were intubated, cut the chest, put the dressing on, the leads, epicardial leads. I had one of our simulation specialists created the chest tubes for me and made clotted blood in them, pacers, even the IV pumps that I show over here. We didn't really need to have the actual drips, just to have the lines. So they could go through that process of draping the patient, positioning, understanding what's important, what they can have access to. So this was the inside of the mannequin. This is where I cut the chest, and we did the outside skin. We moulaged the edges of it. We also cut the chest plate, which was thin enough in this mannequin to do this, but left the one edge still connected, so you had that resistance. Used some heavy craft wire to wire the chest shut, and added a few extra drilled holes to have enough suture material so they could even practice cutting sutures, counting, being accountable for the sutures. The material in this mannequin was perfect to put the rib spreaders in, and they were able to go through that process. And I put a laminated heart inside just to say they made it to that spot. We are working with our 3D printer to hopefully get a actual 3D heart to put inside this. Haven't gotten there yet, trying to find the right material. So the sim was started. We went to the first facility that requested it, actually did it in a conference room, and showing these pictures how once it's all draped up, everybody got to practice gowning up, and it really gave them that feel that they were in the room. We used vital signs that were from the case using our simulated software, and the small little clip I have here, you can see the actual case. They were practicing it, doing all the steps, draping, going into the chest, hearing the beeps. It really put them into that environment, which worked out really, really well. And they really liked it. So once we did the case, one of the most interesting things we found after going through the case was the cart itself and the actual open chest tray. The picture on the right was what was initially used and caused all the confusion. It was a very involved tray that was used for the tertiary center that has a lot more complex cases, high-risk cases, so they need more pieces. It literally had a bar with 60 pieces of equipment on it, and when they picked it up, it slid off, and everybody was like, that is a lot of equipment. No wonder everybody got confused. And they were saying names of things they didn't know what it was. So we went to something, we were looking at it, and the picture on the left, to something that was a lot more similar and what you truly need for a bedside case, and especially for a facility that may only do them once or twice a year, something that would be, less confusing. So they came down to figuring out that this is all you really needed in this small case was a 10 blade, your straight Mayo, curved Mayo scissors, your wire cutter, your chest spreader, your wire twister, and your DeBakey forceps, and then some closure material. Very small, something very easy. They were able to train these nurses because a lot of the outlying facilities don't have the trained staff that are dedicated to open heart being scrub technicians and doing this on a more routine basis. So this was perfect for them, something they could be familiar with and change the whole outcome. We were able to take it from not just that one outlying facility, but to our other facility. And we started doing it in the rooms, which was huge. This is what we call in situ simulation. Set it up in the room. They're able to bring their carts in, able to really see where's the best way to do people to put themselves, what's appropriate. And we are now doing this multiple times a year. We were able to look at their carts, and the cart is on the right here, able to model it, and it actually changed even how they model it at all the facilities. They put the labels on the outside, made everything much more accessible, and it really has changed the face of how they're doing this open chest resuscitation. There is another picture here on the bottom left that does show that nice tray. Super simple, don't need a lot of space. You can maintain that sterile environment, and it's something very simple. They open the pack, they're able to hand that surgeon that small box, have it on a bedside table, less chance of losing stuff, things falling, contaminating your field, and they can do what they need to do. The other thing that came out of this was now they can use it for being more surgically conscious, doing that surgical draping, aseptic techniques in the sterile field. It is being used for surgical scrub classes where they are training their staff to be able to set up those sterile fields, to drape the mannequin. In the past, they would just kind of tape the drapes on a bed, and it really didn't give them that true feel. Now they really like this. This mannequin is extremely portable, very easy to use. So they're able to put it on their bed. They go through the process of draping, and having all those lines and having all those appropriate things in there makes them aware when they're draping what they have to be able to access, because nothing is worse than having to climb under the drapes because you didn't leave a line out that you needed to get to. So they will be able to become comfortable with the uncomfortable. And these are definitely for all that staff that don't do it on a regular basis. And it really helped. So just showing some more, and we got more interdisciplinary. We've had surgical techs coming over to help now. We've had the physicians, the PAs. We've had everybody who's involved now come over and help teach. And this photo is showing the one surgical tech who has been doing on the search. She is on the cardiothoracic team and has been doing this for multiple decades. And she was thrilled to come over and help teach these newer nurses how to do an emergency scrub and participate in this open chest arrest. Just have more pictures showing how we have done it in different areas and setting up all the equipment. Another picture of how we've opened the chest. Again, how it looks so realistic when you can drape, do everything appropriate, even practicing moving leads, little things that you don't think about, even something as simple as the suction catheter. How do you hand that to the surgeon and not contaminate your field? Being able to practice it in this environment has been invaluable. So some more pictures of the mannequin, very simple to make. Again, it was very low fidelity, did not require a lot of equipment. You don't have to have all the blood, all those high tech stuff. It's truly a process sim. So to be able to do this and set this up was extremely easy and effective. So the outcomes that came out of this, which was huge, was changes to that open chest cart, improved that tray. We have ongoing staff education. It is now being used at least twice a year, sometimes 3 times a year at the outlying facilities, and the tertiary center is using it quarterly. We go to their unit and we do it right on the unit, and it has been invaluable because of that training. And then the policies were all updated due to that. Again, just showing that tray. This is how now it is in all 3 facilities, and this is these new trays, which has been huge. The carts, just close up photo of the carts, showing the labeling, how it is a lot easier to read. And they did a really kind of unique feature where they started. The one facility has one that has drawers on both sides. So the left side is everything to open the chest. The right side is everything to close the chest. And keeping it streamlined between hospitals, because these doctors do float between hospitals, has been keeping everybody on the same page. Policies, again, there were some changes, and really they realized there really was no good policy as far as who's supposed to respond and what their roles were. So they were able to change everything, and again, it is across the network, across all the hospitals. Where do you stand? Where do you position yourself? Where does the equipment stand? It really made them realize these type of cases, you can have so many people and so much equipment, people don't know where to move, and it become very chaotic very quickly. Having established standardized protocols and policies has absolutely improved the process, and even showing where to position when they bring ECMO in and have to cannulate the patient. And again, more just everybody involved, having more interdisciplinary with the surgeons, the surgical techs, everybody, they've all been thrilled by this. So we've been very excited to do this simulation, and we really, really like it. So if you guys have any questions, I'd be more than happy to answer. Please email me. Happy to answer. Happy to help guide anybody in this type of education. And I really appreciate everybody's time this morning.
Thank you, Doctor, for your informative presentation.
Thank you.
You can drop your email ID in the chat box. If anyone has any question, they will email you.
My recent work, called The Anti-senescence Effect of beta-hydroxybutyrate in Hutchinson-Gilford progeria syndrome, involves progerin clearance by the activation of AMPK-mTOR-autophagy pathway. First of all, I'm going to talk with you about what is progeria. Progeria is a premature aging syndrome, and the main cause of the miss in this syndrome is heart failure. This syndrome is caused by the mutation in lamin gene, which consists in a C by T transition in exon 11, creating a new splicing donor site that induces the deletion of 50 amino acids that contains the metallopeptidase recognition site. Briefly, perlamin A undergoes several post-translational modifications like farnesylation, methylation, and final cleavage. However, in progeria, this doesn't occur that way. The final step doesn't occur because the loss of these 50 amino acids. This induces the production of progerin, a permanently farnesylated protein. Currently, there is only one approved therapy for progeria, lonafarbid, a farnesyl transferase inhibitor. This prevents the production of progerin by blocking the farnesylation step. However, the effects of this drug in these patients is very limited. It only induces the lifespan extension by 1 year or 2. Okay? Progerin itself induces several cellular alterations, like nuclear aberrations, impaired autophagy, nuclear expansion, endoplasmatic reticulum stress, mitochondrial dysfunction, among other alterations. Altogether induce cellular senescence, which is characterized by cell cycle arrest and apoptosis resistance. Several hallmarks of aging recapitulates in progeria, and interestingly, progerin protein has been found in non-AGPS tissue and cells, like in normal aged cells and dilated cardiomyopathy. Okay? As mentioned earlier, currently there isn't an effective treatment for progeria patients. This encourages us to propose beta-hydroxybutyrate for AGPS treatment. But why? Well, BHB has been extensively studied in the last years. It is a ketone body synthesized after lipolysis, stimulus like exercise, caloric restriction, fasting, and ketogenic diet. Once the free acids are released to blood circulation, they get into the liver mitochondria by carnitine importation, where are converted to acetyl-CoA, then to BHB production by beta-hydroxybutyrate dehydrogenase enzyme. When the levels in blood increases of BHB, we are talking about ketosis, okay? Interestingly, ketosis can be achieved by the consumption of ketone esters or other nutraceutical supplements that, by the way, are now on market. However, several studies reveal that aside of its energy production role of BHB, mild ketosis has some therapeutical effects on, by example, cardiovascular, cartilage, and liver senescence, Alzheimer and multiple sclerosis, extension of heal span and lifespan in mice and C. elegans, and attenuates heart failure. How does BHB do this? Well, by modulating several hallmarks of aging, such as mitochondrial dysfunction, cellular senescence, and loss of proteostasis. BHB has been found to induce autophagy, by example. For these reasons, we wonder whether BHB could have some anti-senescent effect in progeria, okay? To do this, we evaluate several markers of senescence in HGPS fibrilless donors, like beta-galactosidase activity, which is elevated in the HGPS, as we can observe here. And after BHB treatment, this is reversed. Also, we evaluate cellular senescent morphology that is characterized by flattened cellular morphology, as we can observe here and here. And interestingly, after BHB treatment, this is reversed. Also, nuclear expansion was evaluated and was reversed under the treatment. We also evaluate B21, decisive protein involved in cell cycle arrest in senescence. That is upregulated in HGPS, as we can observe here and here. And BHB treatment reversed this, okay? Lamin B1 decrease in senescence, as we can observe here, and here, and here, and was restored after BHB treatment, okay? We also evaluate, give me a minute, we also evaluate nuclear aberrant morphology and DNA damage response. But after BHB treatment, both parameters were reversed, okay? We also evaluate autophagy that is impaired in HGPS, as we can observe by the decrease of LC32 that is lipidated, indicating autophagosome formation on the chloroquine treatment, which chloroquine stops the autophagy degradation, okay? But after BHB treatment, this lipidation was increased, indicating the formation of new autophagosomes. Also, we evaluate P62, a molecule that is normally eliminated by the autophagy progression. We observed that was upregulated in AGPS, indicating impaired autophagy elimination, but after BHP treatment, this was diminished, okay? Several autophagy inducers have been studied for progeria therapeutics. Most of them also induce anti-senescent effect, which means that these autophagy inducers induce anti-senescent effect and progerin clearance, like rapamycin, MPK agonist like 991, and P300 inhibitor and acetyltransferase A485. Okay, this induce autophagy, induce progerin clearance, and are involved all of this in the anti-senescent effect. Okay. Therefore, we question whether BHB also induce progerin clearance. As we can observe by immunofluorescence, it does, and by immunoblot. BHB induce anti-senescent effect and also inhibitor and SBA that inhibits MPK and ULK1. These both proteins, along with mTOR, is related to autophagy initiation. Okay? When cells were treated with BHB, MPK activity increases as observed by the phosphorylation of ULK1. Also, mTOR activity decreased as observed by its direct target S6 kinase 1. Okay? Also, P62, as observed previously, decreased, and progerin also, as we can observe here and here. This means that BHB induces MPK activity, inhibits mTOR-C1, and activates ULK1, which favors autophagy initiation. To confirm this, we use, as mentioned before, S/A, this inhibitor. What we observe here, okay, that progerin decrease, P21 decrease, P62 decrease, and senescence decrease under BHB treatment alone. But when we combine BHB with S/A, all these effects were blocked. We cannot see an antisense effect, and progerin doesn't change. We also evaluate mitophagy, a selective process for the elimination of damaged mitochondria, okay? That involves autophagy. We colocalized P62, a autophagosome marker, and stained mitochondria with mitotracker rate. We can see in these vehicle-treated AGPS cells that mitochondria and autophagosomes are colocalized. This means that damaged mitochondria is accumulated within the cell, okay? But after BHB treatment, this colocalization diminished, indicating that maybe mitochondria is being eliminated. However, SBA and BHB co-treatment reverse this. Then we colocalize lysosomes with mitochondria. As we can see here, there is a very low colocalization between mitochondria and lysosomes. But after BHB treatment, this colocalization increased and is reversed after SBA and BHB co-treatment. This means that mitochondria is accumulated in the cell, it cannot be eliminated, but BHB treatment facilitates this. Lucky mice that is a knock-in with the mutation to induce the production of progerin. We start the treatment with this ketone ester. This ketone ester undergoes some steps for the release of beta-hydroxybutyrate, like the conversion of this ketone ester to BHB and butaneidol by the good esterases, and then the butaneidol is converted to beta-hydroxybutyrate by the aldehyde kinase. Okay, and this induces the ketosis state in the mice. We start this treatment at the week 32 age of in the mice, and then made some analysis of glucose and ketone levels, the strength and Pericardial index. Also, we're gonna evaluate electrocardiogram and some tissue analysis. Okay. What do we observe? We observe a diminished of glucose levels before the treatment, and beta-hydroxybutyrate doesn't change. Then we administrate and see how this change within 60 minutes after the administration. Glucose doesn't change, and we were able to induce ketosis state in the mice. The strength, we compare the wild type, the vehicle AGPS group, and the treated group, and we observe the diminish of the strength in the AGPS vehicle group, but after the treatment, this strength was increased. Also, we see how give me a minute. Also, we see, give me a minute. Also, we see how the Friedel index increase progressively with the time, with the age, but in the treated group, this doesn't occur. It seems that the progression stops. As we can see here, before the treatment, the AGPS have some value in the Friedel index, but after the treatment, 1 month later, the Friedel index keeps increasing. But in case of the AGPS ketone group, the treated group, the Friedel index remains the same. It doesn't change. Okay. These are promissory results for progeria treatment. We are with other studies ongoing. We have the heart tissue, we're gonna evaluate it. We also have some data of electrocardiogram. We are going to complement this. But so far we have some improvements in this mice after the ketone ester treatment. And this is all. Thank you for your attention. Thank you.
Thank you for your wonderful presentation. You can share your email ID in the chat box. If anyone has any question, they will email you.
Esta presentación, bueno, este método tiene ya pues más de 15 años que ha sido desarrollado y es una intervención centrada en la persona. Como sabemos, esta intervención centrada en la persona pues es considerada como un elemento esencial en la calidad de atención y en la satisfacción del paciente. Entonces, inicialmente se desarrolló para el cuidado de la diabetes a partir de una tesis doctoral que desarrolla la doctora Softman, y ella habla de que pues en el cuidado de adolescentes que tenían diabetes tipo 1, actualmente este padecimiento, este método se aplica pues en varios padecimientos, como es la esquizofrenia, el cáncer de mama, el cáncer, la endometriosis y algunos otros problemas. Inicialmente consta de 21 hojas de reflexión en un orden predefinido que ahora explicaré más adelante. El método de autodeterminación guiada promueve la reflexión y la toma de decisiones compartidas entre el paciente y el personal sanitario a través de un componente motivacional y el desarrollo de habilidades para el manejo de la autogestión de la diabetes de forma cotidiana. Ustedes podrán encontrar la metodología empleada en la publicación que se encuentra en la Revista Mexicana de Enfermería Cardiológica. Este método requiere de una relación dialógica o bien de desarrollar habilidades efectivas de comunicación, y bueno, pues promueve que el profesional de la salud reciba formación en relación al uso de estas habilidades, pues como la escucha activa, la aclaración de valores, y como las que nosotros vemos representadas en la diapositiva. Esto es consistente con lo que la Organización Panamericana de la Salud habla en el libro sobre diálogo de saberes, y pues aquí nos habla de tratar de enfatizar
o comprender y entender los problemas y necesidades del paciente, y mediante estos diarios de reflexión y tratando como de establecer acuerdos con el personal de salud. Plantea la necesidad de dar voz a los actores centrales de los procesos de salud, considerando el propio contexto en el que se desarrolla. ¿Cómo se inicia el método de la autodeterminación guiada? Pues se inicia llenando hojas de reflexión que están previamente ya estructuradas. Es el punto de partida para el establecimiento de la comunicación entre el paciente y el personal sanitario. Y a partir de ahí se elaboran unas listas independientes sobre temas que tanto el paciente como el profesional de salud perciben como difícil en relación al autocontrol, en este caso de la diabetes. Y bueno, pues una vez que se tienen estas listas independientes, se pasa a este punto de la solución de problemas de forma conjunta, se establecen acuerdos y se toman decisiones, ¿no? Y dentro de este proceso se motiva al paciente a asumir su autonomía y su responsabilidad a través de la negociación de planes y objetivos de tratamiento específicos, pues muy acorde a las necesidades que ellos tienen. Este método pues está entendido como una intervención, ¿no?, centrada en el paciente. Y bueno, pues este método cambia la naturaleza de las interacciones que tenemos en la relación con los pacientes. Hacia el principio, además de los diarios de reflexión, el principio es establecer una relación significativa y se alienta pues a enfocarse en la comprensión eh, de las perspectivas y prioridades que el paciente tiene, y no solo en prescribir un tratamiento estándar o estructurado, sino en centrarse solo en la falta de y no solo centrarse en la falta de progreso en el control de los parámetros clínicos, sino en este establecimiento de esta relación significativa. Bueno, esta atención centrada en el paciente, pues sabemos que enfoca la atención básicamente en las necesidades y expectativas que el paciente tiene, y más allá solo de abordar la enfermedad como tal. Bueno, un punto central en estos diarios de reflexión y la atención centrada en el paciente tiene que ver con las habilidades para la vida. Estas habilidades para la vida pues son capacidades psicosociales que permiten a la persona afrontar de manera efectiva los desafíos y exigencias de la vida diaria. Entonces, Hoffman en su tesis doctoral aborda con su equipo de investigación, adiciona estas habilidades para la vida, inicialmente un establecimiento de esta relación mutua y significativa, después procede a la autoexploración, a la autocomprensión, y posteriormente incluye ahí otro punto sobre toma de decisiones compartidas, para finalmente llegar a establecer la acción que se ha planeado y una retroalimentación de la acción. Entonces, esto es la propuesta que se hace desde esta autodeterminación guiada. Y bueno, pues los efectos que tiene la comunicación y que reporta la literatura respecto a esta comunicación del paciente y personal sanitario, dicen que es un trato más confidencial y que se tiene un mayor intercambio de conocimientos compartidos, no solo del personal sanitario, sino también de lo que el propio paciente conoce sobre su padecimiento y vive diariamente. Habla también de que otro efecto es que se crean estas soluciones de manera conjunta y centrada en asuntos de difícil control de la enfermedad, y que realmente está viviendo en el día a día el paciente. Una mayor conciencia de encontrar posibilidades y recursos para una mayor autonomía en el control de su enfermedad, porque ellos pueden ir a revisar los diarios de reflexión y les pueden encontrar ahí, resignificar nuevamente lo que ellos han escrito o lo que han establecido como decisiones. Y se reconoce al personal sanitario pues también como alguien con quien se puede conversar y no solo con quien se va a recibir una indicación o una receta, sino alguien a quien se le tiene apoyo o se tiene apoyo de él, ¿no? O de ello. Entonces, bueno, pues las hojas de reflexión permiten tomar una mayor conciencia o tomar conciencia y expresar con las propias palabras de las personas las dificultades que perciben al vivir con diabetes en el día a día, y pues esto hace que las personas tengan una mayor confianza, mayor comprensión y que se facilite una mayor colaboración porque no se sienten juzgados y bueno, se van tomando las medidas pertinentes para poder avanzar en el autocontrol de la diabetes. Estos diarios de reflexión pueden, en la revisión de la literatura encontramos que hay investigaciones donde incluyen conversaciones grupales y por otro lado conversaciones individuales. Bueno, pues en las conversaciones grupales se perciben como valiosas, inspiradoras y alentadoras por el hecho de escuchar otras experiencias y, bueno, conocer a personas que tienen la misma enfermedad crea un sentido de pertenencia y mitiga este sentimiento de soledad no deseada que ahora vemos desafortunadamente mucho más presente en nuestros pacientes. Y también ayuda mucho a mejorar el funcionamiento psicosocial en la interacción que se establece en estas sesiones grupales. También los pacientes mencionan que estas sesiones los inspiran a buscar otras soluciones y a encontrar formas alternativas y significativas para la vida, para resolver sus problemas de la vida diaria. Y por otro lado, las sesiones individuales pues se abordan o se mencionan en algunas de estas autores que han investigado sobre que los participantes asistieron a conversaciones individuales, completaron en mayor medida la intervención que se había desarrollado y tuvieron también una reducción en los niveles de hemoglobina glicosilada frente a los que no habían tenido estas sesiones individuales. Bueno, participar en el programa de asesoramiento con hojas de reflexión, de acuerdo a lo que los pacientes dicen, es que pues los acompañó en su rutina diaria porque tuvieron la oportunidad de escribir lo que vivían como desafíos en el día a día y no solo como ir a la visita médica o a la visita a los servicios de salud, sino que tenían esta oportunidad de ir haciendo una reflexión casi de manera cotidiana sobre estos problemas. Y algunos participantes, incluso después de terminar el programa de intervención inicial, volvían a mirar estas hojas de reflexión acerca pues, de esos pequeños desafíos con los que se encontraban y pues obtener de esa reflexión la motivación y reenfocarse en nuevas posibilidades de atención o autocontrol en su problema de diabetes. Bueno, como conclusiones, podemos comentar que el método de autodeterminación guiada es una intervención centrada en la persona. Como sabemos, esto es importante en la calidad de atención y por otro lado, estas hojas de reflexión inciden en las habilidades para manejar las dificultades de autogestión de la diabetes de forma cotidiana. Incluso se menciona que disminuyen los eventos adversos, por ejemplo, con el uso de este tipo de métodos. Y bueno, pues en algunas investigaciones, los se han reducido la cantidad de hojas de reflexión porque la autora original habla de 21 hojas de reflexión y bueno, en algunos estudios ya más recientes se ha disminuido la cantidad de hojas y se habla de 8 a 10 sesiones grupales, ¿no? Se requiere pues habilidades avanzadas de comunicación profesional. Aquí es importante que los profesionales nos preparemos en estas habilidades para poder avanzar en la aplicación de este método de autodeterminación guiada. Y también requiere una práctica enfocada en la resolución de problemas de forma conjunta con pacientes y profesionales. Yo enfoqué la revisión hacia los profesionales de enfermería, sin embargo también pues obviamente han participado médicos, dietistas, educadores en diabetes, trabajadores sociales y algunos otros profesionales sanitarios. Las hojas de reflexión son determinantes en tomar conciencia y expresar las verdaderas dificultades por las que atraviesan las personas con diabetes. El uso de este método también cambia la naturaleza de las interacciones que establecemos con nuestros pacientes hacia una mayor comprensión y pues por otro lado puede verse también como todo un desafío. Sin embargo, creo que es importante abundar en investigar con mayor profundidad la aplicación de este método de autodeterminación guiada. Muchas gracias.
Thank you, doctor. You can share your email ID in the chat box. If anyone has any question, they will contact you. Thank you.
Gracias.
Next, we'll be
diplomas in advanced heart failure, clinical research, and I have published case reports on cardiac leiomyosarcoma, uncorrected ventricular septal defect, catheter-related complications and thrombosis, and my clinical work focuses on coronary artery diseases, heart failure, valvular disorders, and complex cardiovascular complications. I am pleased to present a case report published in the British Journal of Cardiology, entitled Vascular Terror: The Strange Nightmare of a Knotted Guidewire During Central Venous Catheterization, a case report. So the central venous line insertion is a common procedure in the hospital setting, but as an invasive procedure is not free from potential complications. These complications include infectious, thrombotic, and mechanical aspects. The mechanical complications include vascular perforation, arrhythmias, cardiac perforation, tamponade, and exceptional knotting of the guide wire. Well, we presented a 79 years old woman admitted to another hospital unit for dyspnea at rest and hypotension. The final diagnosis was community-acquired pneumonia and septic shock. This patient required initiation of a MINS and placement of a right subclavian central venous catheter. During the procedure, resistance to the advancement of the guide wire was detected, which could not be extracted and entrapped the guide wire. This is the X-ray of the patient. They decide to perform an interior posterior chest X-ray that shows a knotted metal guide in the right subclavian region that prevent the removal of the guide wire. Well, the other hospital refer this patient to the interventional cardiology service of our Center for Percutaneous Extraction. We made a computed tomography with three-dimensional reconstruction which demonstrated the intravascular position of the guide wire. So this is the image of the computed tomography with 3D reconstruction that shows an embolized guide in the right subclavian region, displaying exit and re-entry at the level of the brachiocephalic trunk, with a spiral trajectory, knotted configuration, and cephalic migration. The treatment of this complication is the extraction. A right femoral venipuncture was performed using an 8 French introducer, and fluoroscopy was employed to visualize the distal end of the guide. We used the Merit Medical end snare, 12 to 20 mm 3-loop snare wire extraction device, to snare the tip of the wire under fluoroscopic guidance and extract it completely via the right femoral root, removed without complications. So here we have the image of the Merit Medical and snare device and the tip of the embolized guide. So this is a table where enlist all the mechanical complications reported in the literature. The mechanical complications associated with central venous catheterization are embolization, migration, fracture or vascular entrapment of the guide wire that can occur in 1% of the patients. Noting an intravascular entrapment are even more infrequent, with only one case report in the literature. There are different risk factors that involves the operator inexperience, history of multiple CVCs at the same site, subclavian catheter placement associated with costoclavicular pinch syndrome. So here we have a diagram that shows the mechanism of the costoclavicular compression. This could be passed in the patient. The guide wire was squeezed between the first rib and the clavicle. The guide wire embolism is a serious complication. It has a high mortality rate between the 60 and the 71%. That results in vascular blockage, myocardial perforation, thromboembolism, arrhythmias, endocarditis, and sepsis. The percutaneous extraction is recommended due to its severity, even in asymptomatic patients. So this technique was introduced in the 1960s. Is the gold standard in the removal of the intravascular foreign bodies. There are different materials available for percutaneous extraction, like loop catheters and basket devices, biotomes, and raptor forceps, as we seen in these two images. The choice of these materials is guided by the preference and expertise of each doctor provided. The percutaneous extraction is made through femoral venous action, preference for right femoral access. There are some key advantages: ergonomics in the handling of the instrument, the possibility of the use larger caliber, the ease of puncture, effective and safe compression at the end of the procedure, and the option of using the contralateral femoral vein in challenging situations. So we have an ideogram depicting the hangman loop snare technique in another patient, but this exemplifies the case in our patient. The percutaneous extraction have a success rate of the 97.8%. And the possible complications are transient ventricular tachycardia, myocardial, valvular or vascular perforations, and flight of tricuspid valve with permanent tricuspid regurgitation, hematoma over the puncture site. When percutaneous extraction have failed, there are some alternatives. The last resort and reserved for exceptional circumstances, surgical approach via media sternotomy is contemplated. This is to reserve the ensure safe resolution of the situation. So, well, it is crucial to highlight the substantial and consistent evidence that demonstrates the advantages of ultrasound guidance in CVC procedures. This approach significantly minimizes the risk of complications, including failed cannulations, arterial puncture, hematoma, pneumothorax, and hemothorax. In conclusion, guidewire-related complications during central venous catheterization are mainly mechanical in nature. Retention, coiling, and knotting are extremely rare events, with only isolated cases reported in the literature. Risk factors include operator inexperience, previous CVC at the same site, multiple punctures, fatigue, and night shift. Another conclusion is that the diagnosis and management should be multidisciplinary, often require vascular surgery involvement, and the use of ultrasound guidance for CVC significantly reduces the risk complications. Well, at the end, the most important thing we must remember is that every piece of data, every discovery, represents an opportunity to improve medical practice and, above all, the quality of life of our patients. Thank you very much. Have a good day. Thank you.
Thank you, Doctor.